Fear. Right now, there is a lot of fear because of COVID-19. People are scared of leaving their homes, scared of shaking hands with humans, and scared of going to hospitals because that is where COVID-19 patients go. So even if we need to see a doctor, we stay at home, and sometimes waiting could make things worse.
When news of COVID-19 spread, people stop coming to the hospitals. Even if they are not infected by the virus, they become infected by fear.
But did you know that hospitals may be the safest place in the world right now? When they started admitting COVID-19 patients, they had isolation rooms and special wards for these patients. One ward for COVID-19 patients, separated from the rest of the hospital, leaving the rest of the hospital safe for everyone else. So every time a COVID-19 patient walks in, they get dedicated nurses to take care and support them.
Safety is our number one priority all the time. This helps to keep not just our staff, but also our patients and the general public safe.
They have doctors that specialize in infectious diseases, separate security 24/7, separate disposable cutlery, and even separate air ventilation systems to make sure even air doesn't go to other parts of the hospital. This separation is vital to keep everyone safe because for all other patients, it's the new norm. Many people still need hospitals, especially when they have worrying symptoms like chest pain, vomiting, or sharp pain in the stomach that need urgent medical attention.
Because of our very strict protocols and safety measures, our hospitals are safe, and that is a fact.
Because everyone, from senior management to doctors to nurses to security guards to chefs, is doing the impossible to keep the hospitals safe for you. So, only if you need urgent medical treatment, stay home, be safe, and keep healthy. Health insurance is complicated, so let us simplify it for you. This is a plate of delicious fried rice. It's like the basic health insurance that we all enjoy. It can protect you when you fall ill and get hospitalized, and helps you save money. But what if you had the choice to upsize it? Add this, this, and this to your meal. All of a sudden, your meal has more flavors. With private health insurance, you can enjoy more options. Your hospitalization and surgery are covered. You can choose your own doctor and see them in 48 hours. You just need to focus on recovering and leave the rest to them. Healthcare isn't supposed to be confusing. It's supposed to help you.
A very good afternoon to all of you who's watching us live. Thank you for joining us this afternoon. And welcome to the Mount Elizabeth Hospital's Annual Medical Seminar 2020. I'm your host for today. My name is Charlene. Yes, today is the final installation for our annual medical seminar. Now, this event is jointly organized by Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital. This virtual event is hosted via 4 lunchtime webinars featuring over 9 medical leading experts from our Singapore. And also we'll be touching on topics relating to the new norm of bringing healthcare forward. So today we're really delighted to have our GPs, our specialists, as well as medical professionals who are watching us live. A very good afternoon to all of you and a warm welcome once again. Okay, so for those of you who have missed out on our very first few sessions, this is how you can watch the replays. Now you can visit our event website. And also for those of you who have registered using your MCR number, you're eligible for the CME points. Now before we moved on, right now we are shooting live from the Presidential Suite from the Mount Elizabeth Novena Hospital. And let us take a look at our presentation topics as well as our doctors who are presenting today. So for our topics today, we have Dr. Ronnie Tan, the urologist, who will be presenting on restore good urinary flow without hurting intimate relationships through UroLift. And we also have urologist Dr. Tan Yong Kan. He'll be presenting on Resume, steaming away your enlarged prostate, a minimally invasive treatment for prostate enlargement. We also have with us orthopedic surgeon Dr. Alan Chong, and he will be presenting on robotic surgery and ringside medicine. Last but not least, we'll have a panel discussion Q&A, and this is moderated by urologist Dr. Tan Ye Hong. And right now, let us take a look at some of our housekeeping announcements before we move on. Before we start, some reminders for you to do. For our Q&A, on the bottom right of your screen, there is a Q&A button where you could call out the Q&A sidebar. Simply click on it and also post your questions. So once the question is approved, it will appear under the live questions list. So you may close the Q&A overlay once you're done and call it out again if you have more questions. So this webinar is also accessible via our Mount Elizabeth Hospital's YouTube channel. A gentle reminder for doctors to log in via the event website for your CME points. For our viewers on the YouTube channel, you can also post your questions via the comment box. So if you are posting on social media, do remember to tag us and hashtag MEAMS2020. If you encounter any technical difficulties, please contact us. Our crew are on standby to assist you. At the end of the session, please help us to fill out the feedback form. Your suggestions and feedback will help us to improve our future events. Last but not least, we'd like to thank our sponsors for the event. Platinum sponsor, Teddyflex and Pfizer. Gold sponsor, Sandoz. And silver sponsor, Beringal Ingraham. All right, without further ado, let us now welcome our first speaker for the day, Dr. Ronnie Tan. He is urologist at Mount Elizabeth Hospital, and he has a passion for the treatment of sexual dysfunction and specializes in the assessment and treatment of male subfertility. So let us welcome Dr. Tan, please.
Hi, thank you. So my name is Ronnie. I'm a urologist and andrologist. So today I'll be talking about the new minimally invasive treatment known as UroLift for the treatment of benign prostatic hyperplasia. So when I was a medical student, the treatment of BPH was relatively straightforward. We started with lifestyle modifications and medications. And for those patients who find that the medications don't work, we may proceed on to do surgeries. The most common surgery that was done for an enlarged prostate was TURP, or transurethral resection of the prostate. And for those who are not fit for surgery, unfortunately, they may have to be relegated to the placement of indwelling catheters, or we'll teach them clean intermittent self-catheterization. What I felt was ignored mainly at that time was sexual dysfunction. Men were told to just live with sexual dysfunction. But currently, I think in the current climate, most most men are really concerned about how they can perform in the bedroom. So I'm here to share with you about UroLift. So a survey has been done regarding the choice of treatment. We find that a lot of men actually find that if there's sexual dysfunction within the different types of treatment, they may actually decide whether to go ahead or not to go ahead. Yeah, so this is something that some of us do not broach when we talk about the flow of the urination when it comes to treatment. But if you are able to actually ask your patients, are they concerned about sexual dysfunction, you'll be amazed that actually they will step forward and then tell you this is something they're really concerned about. BPH does not just affect men, it affects the significant other. For example, the wife that sleeps next to him. For this guy who wakes up every night to pass urine a few times, I'm sure the wife or the girlfriend is unable to sleep well. Bladder outlet obstruction also causes some problems with the function of the bladder. Last time we used to think that it's just the flow of the urination that's important, but we know that with a chronic obstruction to the bladder outlet, we find the bladder's health is actually affected. They end up with a trabecular bladder where the bladder no longer is able to maintain a low pressure system so that it does not affect the upstream upper tracts, for example, the kidney function. Because we know that if there's increased pressure in the bladder itself, this is transmitted upwards and the patient can have renal impairment. This is just a picture showing ejaculation. Ejaculation usually is divided in two phases, the emission phase and the expulsion phase. Most men will only experience the expulsion phase. So what happens during ejaculation is before a man is able to ejaculate, the internal sphincter or the bladder neck has to close. So this will let us understand how certain treatments, because it relaxes the bladder neck, as a result the patient ends up with ejaculatory disorders. So some of the unavoidable sexual dysfunction from medications like alpha blockers is that, like I mentioned earlier, relaxation of the bladder neck results in the flow of the ejaculate in the wrong direction back into the bladder. There's no problem to the patient, but the sensation is slightly different. They can still reach orgasm, but they find that it's a dry orgasm. So some patients actually come to us and complain of pain. So should we do TURP? What we do is actually resect the bladder neck. As a result, definitely you can see on the picture on the right side, that's how the semen will then go. There's also possible sexual dysfunction, like erectile dysfunction from the use of medications, especially like 5-alpha reductase inhibitors, because of its effect on the testosterone. Patient ends up with ED. And there's also theoretical risk that the TURP can cause erectile dysfunction at the same time. So must we allow this compromised sexual dysfunction to be something as part of the treatment for urinary symptoms? What about the sexually active men who cannot accept the side effects of the medication or the side effects of the surgery? What about those patients who are not keen for long-term medications? So this is a table showing the risk of sexual dysfunction ranging from retrograde ejaculation, painful ejaculation, decreased volume of ejaculate, as well as erectile dysfunction. So you can see over here that the prosthetic urethral lift has no post-operative sexual dysfunction as compared to the other types of treatment. I think the important thing that we should tell our patients, the patients come to us, we should explain to them what does he want to achieve. If let's say he has no intention to preserve his sexual function, TURP is still a gold standard treatment. It improves the flow of the urination without affecting sexual dysfunction. But if the patient is concerned about his sexual function, then we should we should then tell the patients that UroLift is a good option. And of course, looking at the surgical retreatment rates, we also have to be honest with the patients, because in UroLift we do not resect the prostate, and we know that prostate grows with time, as opposed to TURP or resection of prostate, where the prostate is actually cut open and the prostate can still grow back, causing symptoms. So UroLift or prosthetic urethral lift, what is it? It is actually a transurethral placement of these small permanent implants used to retract the lateral lobes of the prostate to reduce obstruction to the bladder outlet. We can now also use this treatment for enlarged median lobes. This is what the device looks like. On the right will be the delivery device. On the left will be the permanent implant that's left inside the body of the patient. So this picture shows us how it's placed. We do a rigid cystoscopy where we pass a scope through the urethra into the prosthetic urethra, and we fire off these implants. You can see on the figure C, where the needle actually pierces out to the prostate, Figure D will show you the placement of the capsular end piece, and then figure E shows the placement of the urethral piece. So what we are doing is we're actually pulling apart the prostate without cutting it. So it's something like drawing the curtains and then using the curtain ties to pull apart the prostate. So the picture on the left showing before when you have enlarged prostate, and on the right where a good anterior channel is actually produced, and you can see all the way into the bladder neck. So the first UroLift was actually placed on the 16th of October last year in Mount Elizabeth Hospital. And so far I've been certified by the company to be able to do this on my own. Okay, so if your patient should ask you about UroLift, basically it's a day surgery procedure. It takes about 15 to 20 minutes if it's a straightforward case. If, let's say, the prostate is slightly bigger, it will take a little bit longer, usually not more than an hour. It's done under moderate sedation, and most of our patients do not need to be catheterized, and they can resume their normal activities almost immediately. So far, these are outcomes for the blue line. My outcomes compared to the one-year lift study, which is the yellow line, is relatively quite encouraging, I'll say. So what to expect after the procedure? Most patients will have a bit of hematuria up to 3 days and dysuria up to a week. However, they find that there is definitely improvement in terms of the symptoms for the flow on the day itself, and it does get better over the next 4 weeks. So these are some of the examples that I've done for this group of patients. For the interest of time, I'll be showing just a few examples. Poor flow for patients that's not keen for medications, and also a young man with lower urinary tract symptoms, a patient with acute retention of urine, and also for a man with median lobe. So it's a typical patient that we will see, 50-year-old patient with quite severe symptoms, treated with medications, but he is concerned about his problem of retrograde ejaculation. So this is what uroflow looks like. I will do a transrectal ultrasound to size the prostate and to look for any median lobe. I'll do a scope also. So this you can see on the left side is before the procedure. On the right side will be after placing the implants. The lobes are actually drawn apart and tied up like I mentioned, like curtain ties. So the uroflow actually improved to this, and his symptom score dropped from 31 to 9. The patient has stopped his medications and is quite happy in the bedroom now. A 38-year-old, this is a young man with lower urinary tract symptoms. So this flow is really bad for a 38-year-old. His prostate is relatively okay, about 40 grams. So this is what the prostate looks like on top before the procedure and after the procedure of having pulled apart the lateral lobes. This is the uroflow that's done after the procedure. You find that he's definitely happy with the flow, and he has already stopped the medications. Another of my patient who actually presented with a difficulty passing urine. So in the clinic, we found that his residual urine was up to 300 mils. So I actually advised him for catheterization, but he was not keen, and he actually went home. Subsequently, he came back to the A&E for acute retention of urine, and we tried a trial catheter twice, it failed. So he decided for a UroLift. So like I mentioned, I always do an ultrasound. So ultrasound, the prostate was about 24 grams. And this is after the procedure. You can see same thing. The lateral lobes are pulled apart with a good anterior channel. So when he came back for his repeat uroflow, you can see his speed is really off the charts, 40 mils per second, and there was 0 post-void residual urine. We actually dealt with his problem of acute retention of urine. This is a relatively young patient, a 40-year-old patient, who started on medication, Hanau, the common alpha blocker that we use. He was admitted to the Restructured Hospital for syncope. He actually fainted, and he was really upset with the medications. So this is what his uroflow looked like. Really poor for a relatively young man. Did a transrectal ultrasound. His prostate about 20 grams, but he has significant median lobe. So you can see over here, this is the view in from the flexible cystoscopy. On the right side, you actually see the median lobe that is actually protruding into the bladder, what we call intravesical protrusion of prostate, causing a ball valve effect. As a result, he has very poor flow. So this patient, other than tagging away his lateral lobes, I also tagged down his median lobe, which is one of the more advanced moves for UroLift. And I'm happy to say that his flow has improved. This is his flow on follow-up, a Qmax of 17 mils per second with a residual urine of 0, and the symptoms dropped from 21 to 10. So the conclusion, I'll say that sacrificing sexual performance is no longer a must when it comes to treating lower urinary tract symptoms due to enlarged prostate. The early treatment now does not just deal with the flow itself, but I think the importance were actually for us to focus on bladder health, because if we can keep the bladder healthy, we can prevent or lower the risk of renal impairment due to bladder outlet obstruction. UroLift is known not to cause any sexual dysfunction, so for the younger men who are still active, that's something that you can tell your patients is available now in Singapore. It is a day procedure, with minimal disruption to the patient's daily activities. So I find that this form of treatment is something that's getting more accepted by the patients who come to us for enlargement of the prostate. Yeah, so I run my clinics at Mount E Orchard as well as Parkway East. These are the numbers, and if you have any questions, you can also email me after this this session.
Thank you. Thank you, Dr. Tan, for the very interesting presentation. And next up, we'd like to welcome Dr. Tan Yong Kan. He's a urologist from Mount Elizabeth Novena Hospital, and he provides special care in prostate cancers, kidney stone diseases, and men's health issues. So let's welcome Dr. Tan.
Hi. Good afternoon. Thank you all for coming. I'm going to talk a little bit about prostate issues, just like Dr. Ronnie Tan. And I just want to talk about another method of minimally invasive management of the prostate, and we call it Rezum. So I think as we've gone through, we know that prostate enlargement affects about 50% of men by the age of 50 years. And its effects not only on a slow flow, but it has secondary effects on the bladder, causing thickening and symptoms like increased urgency and frequency. And the initial symptoms would be slow flow, and as things get worse, you start getting issues with urgency, frequency. So the usual treatment or mainstay of treatment for prostate enlargement is broken out into two main groups. Usually we talk about alpha blockers and 5-alpha reductase inhibitors for improvement of the flow, or surgical management like TURP, green light lasers, or enucleation of the prostate. They all have their own side effects. You can see here with medications, you can get postural hypertension, retrograde ejaculation, even persistent erectile dysfunction. And you only get about 30% improvement in symptoms. With surgery, we require normally general anesthesia or spinal anesthesia, a lot of retrograde ejaculation, and a small risk of incontinence and bleeding. So where does this whole minimally invasive therapy of the prostate come in? Basically, we are hoping for a procedure that has rapid recovery, is efficacious and sustained. That means it lasts for a good number of years. Can preferably be done without general anesthesia, minimize sexual dysfunction and incontinence risk. So over here I listed a few of this kind of procedures, and on the left is UroLift and Rezum. You just heard about UroLift, and on the right is some other procedures. So today I'll focus on Rezum. Okay, this uses targeted water vapor and as a convective energy to destroy prostatic tissue. What does it mean? So as you know, water can carry energy, and as the temperature of water goes up, it carries energy. But the big change in the amount of energy it carries is when phase changes from a water phase to a vapor phase. That's where there's a lot of stored energy. So a movement from steam back to water releases large amounts of energy. And we do know that tissue is instantaneously destroyed if it hits 70 degrees Celsius. So over here you see a picture of what happens with convective therapy or steam therapy. There is even distribution of the steam throughout the tissue, interstitial spaces. Whereas on the right you see conduction, where the heat source starts on one side and has to move its way across tissue. May not give an even distribution of heat. With it, I also say that it's targeted in the sense that, as the prostate has a prostatic capsule, the steam is confined in that capsule, and so the damage or tissue necrosis is confined within a certain space, thus protecting the nerves of erection. So this allows for targeted therapy. We can target the transitional zone, the central zone of the prostate, while preserving the peripheral zone for this treatment. So over here you see the device. It's a simple device. It's inserted transurethral in the prostate, and the idea is to create contiguous zones of tissue destruction, and thus a targeted shrinkage of the prostate. Over here you see ultrasound image on the left. On the right you see the actual endoscopic image of the procedure. So you can see there's a little white spark, which is actually where the urethra is, and you see a transitional zone where there is obstruction due to its enlargement. So when we are in place, what we do is we fire the needle into the prostate tissue, and then we start the steam therapy. You can see the steam developing in the sense that there is this hyper enhancement on the ultrasound image of the transitional zone as the steam permeates through that space. You also notice that it doesn't go into the peripheral zone. It's confined by the surgical capsule. So at 1 week post-procedure, you see on this MRI image of basically necrotic tissue in the black zones in the prostate. And by 3 months, you get very much increased resorption of that tissue and shrinkage of the prostate. So this is a video showing a pre-treatment with a large median lobe that Dr. Ronnie Tan mentioned. This causes a ball valve effect on patients. And on the right, you see 6 months post-treatment, same prostate with resorption of that median lobe and a nice open channel. So let me show you a little bit about data. 4-year study, randomized control trial, shows a massive reduction in IPSS scores, which is the way we determine severity of symptoms. Qmax or flow increases and is sustained over 4 years. And this is seen in multiple trials. In fact, the bigger the prostate, the bigger the improvement in symptoms, and it is similar outcomes in terms of flow and IPSS to a TURP or laser procedure for the prostate. And more importantly, it has minimal effect on ejaculatory function. We normally quote somewhere around a 5 to maximum 10% risk of retrograde ejaculation. And you can see here on the IEF score or sexual function score, there's no change after the treatment. In terms of complications and discomfort, there is some dysuria, a bit of gross hematuria, and rarely we get a bit of retention and frequency. You can see here this is a treatment failure rates because everyone wants to know. With Rezum, it's about 4.4% at 4 years, and it's comparable to TURP as a gold standard. So I'll show you 2 cases. The first is a 53-year-old Caucasian gentleman. He's got severe lower urinary tract symptoms. IPSS score is quite high, 21, which puts him into the severe range. Was on Cialis and still had a bad score. Maximum flow rate is 10, even though he's on Cialis. Quite bad residual urine, 110 cc. Prostate volume, 54 cc. So he elected to go for a Rezum, done as a sedation, once again as a day procedure, as with any of the minimally invasive therapies. So you see here the ultrasound images on the right-hand side. A little bit of intraprostatic protrusion of the prostate also. So at 3 months, he is off meds. His IPSS score has dropped all the way down to 4. Flow rate has increased. Pulse void is reduced from 110 to 20 cc. And now the prostate volume from 54 cc is reduced to 30 cc, which is basically within the normal range. No complaints of sexual function, sexual dysfunction or retrograde ejaculation. You can see the ultrasound image. This is another patient I recently treated, also about 1.5 months ago, 57-year-old Chinese male. Has a long-standing lower urinary tract symptoms on an alpha blocker, Zetrol. IPSS score is moderate range of 14 with a maximum flow rate of 5.4, so it's quite slow. And also quite a lot of residual urine, 101 cc. Prostate volume is big, 62 cc, the usual is 20 to 30. And if you look on the right-hand side, you'll see that the prostate has quite a significant protrusion into the bladder. So this guy had what we call a grade 3 intraprostatic protrusion, which normally we would just do a TURP or green light vaporization on. But in this case, he elected to have Rezum treatment. So he underwent Rezum, was a 10-minute procedure, done under sedation, home the same day. At 1.5 months, he's off his medications. His IPSS score is 10. His Qmax is about 10.7 with a pulse void of 60 cc. His prostate volume is reduced at from 60 plus to 44, and interestingly, the intraprostatic protrusion that bulged into the bladder, as you can see on the ultrasound, has disappeared. No sexual dysfunction or retrograde ejaculation. And this is still an early stage for him. I tell the patients that usually you will expect improvement in flow by about a month, okay? By 1.5 to 3 months, that's about 3 months, that's when you really see the maximal benefit because the necrosis takes time to be reabsorbed by the body. So I expect his prostate volume to continue to shrink over the next 1.5 months after this. So really the ideal candidate, who is the ideal candidate for minimally invasive therapies? basically patients who are not keen for treatment they're keen for treatment that gives better results than medication. They're not keen for medication, or they have side effects like postural giddiness or retrograde ejaculation. They're not keen for TURP or green light because they're worried about incontinence or bleeding or retrograde ejaculation. They don't really want the permanent implant of Urolift, because I do offer that, but some patients don't like it. They are keen to preserve sexual function, though they understand that there is still a small risk of retrograde ejaculation, and they want something where they can quickly get back to normal activities. Or in some cases, I've done it for patients who are actually not fit for general anesthesia and they're okay with sedation. So in summary, Rezum uses water vapor to specifically target parts of the prostate that are affecting urinary flow, for example, the median lobe or the parts that are compressing the urethra. It's a short day procedure without the need of general anesthesia and with minimal side effects. It gives significant relief for at least the medium term, in the sense that we have data for 4 to 5 years with good maintenance of relief with low retreatment rates. It does not really affect sexual function, though there's a small risk of retrograde ejaculation, and does not cause incontinence. All right, thank you.
Thank you so much, Dr. Tan. Next, we'd like to welcome Dr. Alan Chong, orthopedic surgeon, and he specializes in sports injury as well as hip and knee replacement using robotic surgery. So right now, let us hand over to Dr. Alan Chong, please.
Hi, good afternoon. My name's Alan Chong, and I'm a consultant orthopedic surgeon at Mount Elizabeth Novena Hospitals. I'd like to thank Mount Elizabeth Hospitals and the marketing team for inviting me to talk today at the annual medical seminar. And today I'm going to talk about one of my key areas, which is robotic joint replacement. It's one of my passions. I'm always trying to get better results for my patients, and as a kind of fellowship trained joint replacement surgeon, I feel that this is really the future and way to get better results for anyone who has pain from a worn out knee or hip. One of my other passions is also sports medicine, so I also see a wide variety of sporting injuries, and I have a lot of sporting interests outside of medicine, so I just thought I'd like to share that with you after I've given my main talk on robotic joint replacement. Anyway, without further ado, why do we need robots to do joint replacements? After all, haven't we been doing joint replacements for the last sort of 30, 40 years with no problems? Well, it's true. I think that joint replacements are some of the most successful operations on the planet. I'm talking about knee replacements and hip replacements, but there's still, a significant proportion of people, maybe 1 in 10, who undergo a joint replacement who still feel that maybe haven't solved all their problems, and they still have some issues, particularly with kneeling and squatting, say after a knee replacement. And I feel that in this day and age, we have the technology to be able to plan our operations down to a millimeter and to the 10th of a degree. Previously, in the past, surgeons would have a quick glimpse of an X-ray and do exactly the same procedure they do on every single patient that came through the door. And by and large, this works well, but it doesn't always work well when you've got a patient who's very tall or very short or got a lot of deformity. And this is where really robotics comes into its prime, because nowadays, using this technology, we can really plan things down before the surgery using CT scans, not just X-rays, down to tenths of degrees. And the system, I use pretty much every single robotic system out there, but the system I favor most is called the Makoplasty system. And what is that? That is a system that uses a robotic arm to replace worn out joints in the knee and the hip. It uses a 3D CT guided planning to really determine exactly where the implant is going to go on that particular patient. So it's not a one-size-fits-all system. It can really be adapted to the anatomy and the kind of function of the patient. And it uses a robotic arm which is actually haptic. And that is a type of touch technology which can also provide the surgeon with visual, auditory, and tactile cues to put the implant in the best place and avoid straying out of the operative zone. So you can imagine that haptic technology is actually the same technology that we use on our mobile phones. You press a button and there's a response. And it's the same thing here, but it's really used in a sort of giant robotic arm. And one of the attractive features is that in surgery we try our utmost to avoid damaging key structures in and around the knee, and this robotic arm really prevents us from straying outside those key areas. As I said, patients undergo a CT scan of their leg prior to surgery, and this enables me as a surgeon to determine exactly where I want to cut and also to place my implant. So here I have a short video on how I determine where I'm going to place my implant. So I have like a map of the knee already. I can rotate it around, look at it from all angles, and determine where is the problem, where do I need to put my implant to get the best possible result. And you can see here this is a partial knee replacement. I can see that I can actually move around the implant to exactly where I want to, and this tells the robotic arm where to go. And I can vary this down to millimeters and tenths of a degree. So this is a huge leap forward in terms of preoperative planning to anything that's ever existed before. So, excuse me for those who are squeamish. The slight difference in setup compared to a normal total knee is that we need to put special trackers on the leg, really to allow the robot to know exactly where the leg is in space. And this involves a short registration process of telling the robot where the hip is and where every single point is on the knee. I think we have to register about 100 separate points on the knee. You can see those dots there that I'm pressing there, so that the robot can say, okay, this is this particular part of the knee. And from this data, a huge amount of new ways of looking at the knee have been generated in terms of pressures, in terms of the tracking of the knee, which we simply didn't have before, which were just done by feel. So this is a huge advance in my opinion. And this is the actual process of burring away the bone. There's different sort of tools that can be attached to the robotic arm. In this case, I'm watching the screen, what I'm doing, or I'm burring away at the bone, and I can hear the sound that the robot is making. I can see it on the screen. I can feel that the robot's not letting me stray outside those key areas. So this results in a very kind of accurate and sort of state-of-the-art procedure. So here we have a patient. I like to get my patients walking pretty much straight away, I think, and by and large, the vast majority of those are able to do it. I mean, this is 2 hours following a major procedure, a total knee replacement. This is the same patient 2 weeks later. He's had a left total knee replacement. So he's extremely happy and I'm extremely happy with that. So, we've seen some nice videos and I've talked about how amazing the technology is, but where is the data? And here it is. Here's a systematic review, which is really a collation of information about papers written about the Makoplasty system. And 26 studies with length up to 17 months show that robotic TKR, total knee replacement, has a significantly lower postoperative pain score and also reduced time to discharge compared with conventional total knee replacement. So that's great. So we'll be able to tell your patients who may be candidates for total knee replacement, it's going to hurt less and you'll get out of hospital faster. Comparing CT-based robotic total knee replacement to the normal total knee replacement, functionally in terms of things like being able to kneel or squat, get up and down stairs, pain at night, for example, then robotic total knee replacement also comes out on top. And looking at the sort of positioning of the implant, you'd expect it to be much better with a CT-guided procedure, and it certainly is. So, in summary, here are the things that I think are the pros and cons of robotic surgery. And certainly I think it's, from my point of view, more accurate. It's great to perform the surgery. It can be combined with minimally invasive techniques, which can be produce less pain, reduce length of stay. The long-term data, because it's quite a new technology, is not out there yet, but should be out in the next 5 years or so. I think the disadvantages of any new technique are that we instantly jump on the bandwagon and think, wow, this is going to solve everything. It doesn't, because what you really need to do as a surgeon is to understand the principles of surgery and also the patient that's in front of you to have an excellent result. And this robotic technology enables a good surgeon to become much, much better, but won't teach them basic principles, which I think are fundamental to any surgical technique. So thank you very much for listening to that part of my talk. I'm going to talk about one of my other passions, which is ringside medicine. So last night, I was actually ringside doctor for Collision Course, which was one of the first post-COVID sporting events in Singapore held in the indoor stadium. And this is really something that, as someone who's involved in sports all their life, has had sporting injuries personally and deals with sporting injuries all the time, really, I feel, adds to my practice and something that I enjoy very much. And as general practitioners, it's also something that you can be involved in. You know, the Association of Ringside Physicians is always looking for new candidates and new recruits to be ringside doctors or evaluate athletes post-injury. And so if you're interested in either robotic surgery for your patients or becoming involved in ringside medicine, then please contact me through these details. Anyway, I wish you and your loved ones a very happy Christmas and New Year. Thank you for listening.
Thank you, Dr. Alan Chong. That was truly an eye-opening presentation. Next time, we'd like to get our speakers ready for the Q&A panel discussion. And for those of you who's watching this live, you could also partake in our Q&A together. And this is how. We'd love to have you to call out the Q&A sidebar on the bottom right of your screen. Please pen out your questions. And if you want to make an appointment with Mount Elizabeth Hospitals for referrals of your patients to see Mount Elizabeth Hospital and Mount Elizabeth Novena Hospital specialists within a day, please use this hotline and WhatsApp number. And also for our sponsor, this event would not be possible without all of you. So a big thank you to our platinum sponsors, Teleflex and Pfizer. We also have our gold sponsor, Sandoz, and also silver sponsor, Boehringer Ingelheim. Let us now take a look at our platinum sponsors, Teleflex and Pfizer. Thank you. And now we are all ready for the Q&A panel discussion. Once again, I would like to invite all of you to take part in this interactive Q&A panel discussion with all of us. And this is how. Please call out the Q&A sidebar on the bottom right of your screen. The moderator for today's session is Dr. Tan Ye Hong, urologist from Mount Elizabeth Hospital. And now let us welcome Dr. Tan, our speakers, Dr. Ronnie Tan, Dr. Tan Yong Kan, and also Dr. Alan Chong. Over to you, please, Dr. Tan.
Hello, good afternoon. I'm Dr. Tan Ye Hong, a consultant urologist. I'm very happy to be here as a moderator for this session. I think earlier we have heard the three speakers giving talks very useful, I think, for general practitioners, specialists, and public as well. I think we have a few questions here. I think first I would like to ask Dr. Tan Yong Kan. I think here are a few questions. I think one is that what are the causes for prostate enlargement, and when do you refer the patients to specialists?
I think that's a great question. I don't think we've really come down to exactly why a prostate enlarges, but we know that in the majority of cases it is genetic. I would tell most patients 70% of it is going to be in your genes. If your parents had it, your dad had it, you're probably going to have some issues. Yeah, so that's one reason. The rest of it may be, there is some corresponding information to indicate that potentially diet may have a part to play in enlargement. For example, high-fat animal meals and all that could potentially lead to increased sizes of prostate. So I do encourage people to take on more of a plant-based diet and moderate your intake of red meats, especially fatty red meats. As for the second part of the question with regards to when should you refer, I think the best way to determine the severity of symptoms rather than just talk to a patient would be to use something called IPSS, or International Prostate Symptom Score, and this is a validated score sheet, very easy for the patient to fill on their own. We have both English and Chinese versions that can be used to determine severity. If your patients, even with medications, are into the moderate or severe range, especially severe range, you may want to get them to see a specialist. Yeah.
Okay, I have a questions from the audience. I think maybe I would like direct the questions to Dr. Ronnie Tan. Is there any long-term follow-up that show that the treatments that you propose can reduce the incidence of chronic prostatinia pain?
Oh, okay. So for the UroLift treatment, they have already done studies. The follow-up of about 10 years. In terms of, if you're talking about the longevity of the procedure, most patients actually do quite well. It's just that there is a retreatment rate of about 13.6% at 5 years. In terms of the pain, I would say that there are some patients who may have some chronic pelvic pain from this procedure, but most patients are still okay. So I think the selection of the patient is the important thing here.
Okay, I think thank you for your questions. I think we have one very important question is that what are the charges? Okay, so I would like, I guess they would like to ask what the cost of total cost for Rezum. Maybe Dr. Tan Yong Kan can reply to that first, and then followed by Drs. Ronnie Tan's about the UroLift. I mean the total estimated cost. Yeah.
Okay, so I think it's an important question, and really a lot of costs now is a bit difficult to tell you because a lot of it is also dependent on the insurance plans or panel rates and all that. As you know, medical healthcare has become very regulated in terms of billings and such. But offhand, I'll tell you that the cost of a Rezum treatment, full everything in, is probably somewhere close to 14 to 15,000. The good thing is that because the device that is used to treat the prostate, basically that gun to inject the steam, you only need one gun to inject all of the prostate. No matter how big a prostate is, it is more than enough ability to treat that prostate without having to open another consumable. So that helps to maintain the cost, and so we get a relatively fixed cost because of that. There's less guesswork.
Dr. Ronnie Tan, about UroLift.
Okay, so the difference for the UroLift charges compared to Rezum, yes, like what Yong Kan has mentioned, Rezum only uses one gun. For UroLift, each implant is actually charged per implant because it is something that's actually placed in the patient. So it depends on how big the prostate is. So it can range from 16,000 even up to about 25,000. All depends again on the insurance as well as the size of the prostate.
I think the one of the questions I think the audience like to know is that which one will you recommend? Okay, so which one will you recommend? So is it Rezum's, UroLift, or even ProLift? ProLift is another methods of using a microwave to treat, or even just a conventional TURP. I think Ronnie, you want to answer first,
Sure.
and then Dr. Yong Kan.
Okay, so I think mainly for the minimally invasive surgical therapies, like we mentioned, UroLift, Rezum, and ProLift, these are targeted at patients who are not keen for the common TURP treatments. So it all depends on what the patient wants. Like I mentioned in one of my slides earlier on, if the main concern is about sexual dysfunction, then UroLift may be something that you can offer the patient. But then again, we always tell the patient we need to assess the size and the configuration of the prostate to be fair to the patient. And other things that we will discuss with the patient will be the retreatment rates, and that's something that you'll need to consider.
Yeah, I think I agree totally with Ronnie. Nowadays, in the past where it was very prescriptive, the doctor chooses your therapy. Now we are in a situation where we are more consultative, and we are trying to address the needs of the patient. Patients may have needs for sexual dysfunction that they're worried about. They may have incontinence issue that they are worried about. Even though with TURP we quote a 1%, but to some patients that's not acceptable. So we are trying to meet patients' needs, which is why we have this spectrum of treatments now, as opposed to just a TURP or medical therapy. if you ask me what is better, I do both procedures. I mean, I do all procedures, but I've sort of, in my practice, I've veered towards smaller prostates with UroLift, because I feel that we're not reducing the size, but we're creating a great channel. And I think in the small prostates, you probably have more longevity in the treatment outcomes. With the bigger prostates, I haven't had such a great experience with UroLift. Sometimes they tend to recur. So I've moved more towards Rezum for the bigger prostates. And really, none of these therapies were meant for prostates above 80 grams. Though I've done a Rezum for up to 100 grams or even more. But I think above 80 grams, 90 grams, I think we would still recommend the gold standards like a TURP or green light laser for the prostate.
I think it's very important, I think, to manage the expectation of the patient. I think like what Dr. Tan, both Dr. Tan says, I think you need to discuss with patients, give them the options, and then I think the traditional conventional TRP is still the gold standard, but there are many minimally invasive therapy that can be done, so you offer the patient, but let them have moderate their expectations. Okay, so I think one of the important questions is that they want to all know is that whether they are covered by health insurance, or have they been rejected before?
I mean, from my experience with both therapies, both minimally invasive therapies, there's been no rejections.
Yeah, I think they are considered as therapeutics rather than cosmetic. I think now we want to switch gear to Dr. Alan Chong's orthopedic surgeons. I think the question here is that when do you refer patients for total knee replacement? What is the criteria? When is the time frame?
That's an excellent question, and thank you for asking that. I would say that if you have anyone who has knee pain, whether you suspect it's due to degenerative causes, trauma, torn soft tissues, then it's okay to refer them to a specialist for further investigation. Personally, when I treat a patient with osteoarthritis, I like to manage their expectations by saying, look, let's try physiotherapy first, usually for several months, start you on some medicine for your pain, and also try some steroid injections to start off with. And then, by and large, some people do get better, but particularly those with severe osteoarthritis don't, but at least they feel they've tried everything they can before they've opted for surgery.
Yeah, since I think there's some interest in the macroplasty. Is it for all ages, or younger patients, or older patients, or any selection criteria before you propose the patient to do a macroplasty?
Well,
age criteria?
Again, that's a good question. I think that, end of the day, macroplasty is a tool, and it's a tool to be able to do a better knee replacement, or joint replacement, or hip replacement. The criteria for having that joint replacement is still exactly the same. So, in the past we said, look, we should only perhaps reserve joint replacements, for the elderly patients who basically, but we know from our national joint registries around the world that implants can last 20, 30 years in the majority of people. So we're less concerned, we're less worried about putting in joint replacements in young people. I'm talking about people in their 40s who've had severe early osteoarthritis, but you still need to, again, match their expectations and say, listen, you may not be able to do everything you want to do, and have patients who want to go horse riding or skiing or doing all sorts of activities after joint replacement, and you have to be aware that these implants can wear out over time. So maybe around, in 20 years, maybe 10% of people have a revision. So as long as you've explained the potential risks that you know about to the patient, and you can try and match their expectations, that's generally my approach. But I do not limit it just to age alone.
I think one of the questions that I think related to sports is that after a macroplasty and things, that can I go back to competitive sports? How you advise them?
Well, I would say that, again, we know that professional golfers in the PGA Tour in America do have joint replacements through macroplasty system and go back to the PGA Tour. So it really depends on the individual and the sport. And obviously, if you're playing at a high level, there may be a possibility in your particular sport that you'd be able to return to your sport with some sort of restrictions, but it's not going to, just because you have the operation, it's not going to turn you into, Joseph Schooling or something like that. So I think you need to have a very careful discussion with your patients to not raise their expectations too much, because at the end of the day, joint replacements, yes, it's great if they improve function, but they may need to relieve pain.
I think one of the questions they're interested also to find out is whether the use of robots, is it covered by the health insurance? Is there any issue with that?
I have to say that I haven't had any issues with that, because to me, the robot is there to help me do the procedure, and the actual operation is a joint replacement. So whether it's done with a robot or without a robot, essentially the cost is very similar, and I hadn't had any problems with insurance regarding that.
Okay, I think now we have another few questions that are coming up. I think probably now we switch back to the urologist. I think Dr. Tan Yong Kan, you want to answer this question. One question is that what are the chances of someone below 50 getting prostate enlargement?
Okay, it's not uncommon. We have seen patients even in their 40s with prostate enlargement. I think another interesting category that we deal with is patients with what we call detrusor smooth muscle sphincter dyssynergia. It's a lot of words, but basically it means that the smooth muscle of the bladder doesn't relax at the opening to help with the flow. And we see this in a group of patients starting even in their late teens or early 20s, where their first recognition of the problem is that when they go to the toilet or they go to the army and they're peeing, all the other camp mates pee and walk off and they're still there trying to pee. So there is a group of patients with this kind of problem. So that's a bit different from BPH or prostate enlargement, but it is part of the spectrum of patients with lower urinary tract symptoms. So especially in younger patients, I think it's important to try and differentiate what is the underlying cause. Yeah.
Okay, follow the question is that I think I'll ask Ronnie first before I go back to Dr. Alan Chong. One is that with regards to all these minimally invasive therapy for the prostates, Rezūm as well as UroLift, one of the questions that the question is that would it affect fertility?
Okay, so for UroLift, because it doesn't cause any retrograde ejaculation or erectile dysfunction, so it should not affect fertility. But then again, these are patients who are usually older, so a lot of them they find that fertility is not an issue. I mean, Rezūm does have a small risk of retrograde ejaculation, but it's still definitely lower than traditional TURP when it's almost certain.
Actually, I recently saw a patient in his 40s. He is 45, his wife is 46, and they are desperately trying to have a child. And he has lower urinary tract symptoms with enlargement of the prostate. And we had this discussion about, should I have the treatment now? We're trying IVF, and we got a cycle planned in February. My advice to him is both will probably not affect ejaculation in the long term, shouldn't affect semen quality in the long term, but in the short term, with any procedure, there's going to be inflammation of the prostate, potentially, some blood in the semen, potentially some inflammatory process that may affect the semen quality. I strongly told him, time is of the essence, get your IVF done first, and then after that we can talk about these treatments, because most of these treatments are done more in an elective setting. I know sometimes we do it for patients in retention of urine, but in a younger age group it's usually a more elective procedure. And I would suggest, especially if there is no 3 to 6 month window between when you're trying to get a kid and the treatment, I think better to wait till after especially if you're doing IVF, done your cycles and all that first.
Yeah. I think from the application of UroLift, it still open up the bit of the bladder neck and things like that.
Yeah.
Isn't it potentially that can cause some retrograde ejaculation?
It shouldn't cause the retrograde ejaculation, because when we place the implants, we need to stay clear of the bladder neck, usually about 1.5 centimeters to 2 centimeters behind. Because if you place it too close to the bladder neck, runs the risk of the implant forming a stone on or rather the stone forming on the implant.
I think it's an important question. So we come back to Dr. Lin Chong, and there's one question is what's your view of chondroplasty of the knees?
Well, that's a very broad question. I think that the issue is that chondroplasty covers there's many different techniques involved in chondroplasty, and in a way that tells us that sometimes if you have one technique and it works and it's very successful, then everyone will just use that one technique. And because there's 20 techniques out there, for example, it tells us that cartilage injury is a very serious and disabling problem, which is very difficult to treat. And as I tell my patients, the main reason for this is that cartilage doesn't have a blood supply, and it's very difficult to get something to heal which doesn't heal like normal tissues. So that's why all the various techniques like microfracture and using stem cells and using all sorts of cartilage transfer procedures are taking place. So I think that really requires a very careful discussion with the patient to say that, look, it's not a quick fix. This is going to take you months and months of rehab to heal up. You're going to be quite restricted in the beginning, and you basically have to guide them through, which is quite a long and challenging journey actually. So those are, cartilage problems are actually in young patients are some of the most difficult problems that I have to treat. But thanks for that question.
So, Alan, I think one of the questions that we were also interested is that how can we protect our knees to prevent it from this stage of the surgery? Because surgery is almost the last stage.
Sure.
So how can we protect and keep our knees healthy?
Okay, well, I think that the answer to that is that when patients, if we look at the reverse, patients come to me at the end of their knee life cycle and say, "Look, my knee's worn out. Why did that happen?" And I say, well, look, it's multifactorial. It has many factors. It's because maybe you played a lot of sports and you injured your knees. You ignored that injury. You didn't go to rehab. And your parents, it can be largely, genetic and familial. So if your parents have bad knees, it's quite likely that you will also. But for the factors that we can control, I would say that advise your patients never to ignore an injury and not to play through pain, because that pain indicates ligamentous or meniscal or cartilage injury that can get worse with time if you ignore it. I do encourage my patients to stay active and healthy. If they do get knee pain, I advise them to do low impact activities like swimming or cycling, and to try and go to a physiotherapist to try and strengthen their knees and do the right exercises. I don't really advise them to take supplements, however, because I think there is limited evidence that taking glucosamine or this or that or the other can really prolong the life of the knee. But I think that staying active, having low impact activity and making sure that your knees are flexible and strong goes a long way to preserving your knee.
Yeah, I think I agree with that. I think it's important. I think to keep our weight low as well, not overweight and things like that, to impose too much strains on the knee as well. Yeah. And then one interesting question is that from here is a GP.
Okay.
He is have an interest in sports injury. Yeah. And he wants to be a ringside doctor. Okay. What is the requirement? He got inspired by you.
Well, I thank you very much. I'm honoured that you want to also try ringside medicine. And I think that the way I started out was I basically covered all the local martial arts events in Singapore for about a year before I realised actually it's actually can be a fairly risky proposition, because what you really need is an event where you have more than one doctor and also you have a paramedic team and you have a clear route of evacuation and a certain amount of medical equipment you use. Plus, if you can screen the athletes beforehand for any existing medical conditions, then that's really the gold standard. And luckily, working with One Championship, who are international professional organisation, I've got all that. I can create my own team, and I can bring them to the events, and it's all as safe as you can get it. So, what I'd say is I look at the Association of Ringside Physicians website, and basically you can get involved in many sports in Singapore, despite it being COVID times, like rugby, martial arts, football. It's sort of, you just have to ask around, but I'm very happy to discuss with you if you want to take it further. Thanks very much.
I think for those people who are interested, I think you may want to contact Dr. Alan Chong for further details and how to be a good ringside physicians. I think with that, I think I'd like to take this opportunity to thank all the speakers for this afternoon session. Thank you very much.
Thank you very much.
Thank you.
Thank you, Dr. Tan Yee Hong, for moderating, and also to both Dr. Tan as well as Dr. Alan Cheong for the very engaging Q&A panel discussion. Now, we've come to the end of the Mount Elizabeth Hospital's Annual Medical Seminar 2020. A Merry Christmas to all of you in advance. Now, before you go, if you want to refer your patients to us, to Mount Elizabeth Hospital or Mount Elizabeth Novena Hospital within a day, please call our hotline or WhatsApp us. For the feedback, please submit your feedback via this link. You can also scan the QR code or type out this bit.ly link that is case sensitive. Now, for our previous sessions, please send your feedback via the very unique QR code and also bit.ly link that was sent to you. Next, for all the sessions, this will be uploaded via our event website to view on demand. Finally, we'd like to thank all our sponsors once again for supporting us in this event. Thank you so much to Platinum sponsors, Teleflex and Pfizer. Gold sponsor, Sandoz, and Silver sponsor, Beringal Ingraham. Thank you very much, and we look forward to seeing you next year. Merry Christmas and goodbye.